So some separation in the setting of appendicitis or any obstruction, you look for a lot of free fluid, your debris fluid that you see kind of chunks of fibrinous stuff floating around, and of course abscess, that's kind of easy, and then the air. But that actually doesn't happen so commonly. You see these other things before you see free air. And then consider, and this one's a little bit more subtle and subjective, is you can see the appendix really well. But the wall, either on ultrasound or CT, starts to look a little fuzzy, like you can follow the wall, but then there's a certain part where it just doesn't look quite right. It makes you wonder if that wall broke down. So it's easy, gas-containing complex fluid collection, vascular rim, no internal vascularity. It's like this. You probably see the appendix, you'll just say there's a right lower quadrant abscess, so we will assume that it was perforated appendicitis. Ultrasound, complex fluid in the left upper quadrant. This is bowel, but then all these little pockets. So you kind of really need to scrutinize all the triangular pockets. And with the fluid, so complex. I mean, this is free fluid. It looks like intestinal contents, but it's in the peritoneal space. It's in the peritoneal space. It forms these triangular pockets that surround what are otherwise clear intestinal loops. And, also with perforation, and we see the lower quadrant, the bowel is just really matted. There's no peristalsis, like sit up. And when there's a perforation, usually the intestine kind of goes on lockdown. It is going to be doing its job, so you'll be getting, at the very least, a functional ileus just because of all the irritation. This actually, and we see a sagittal view of the liver, and we see two things. We see pleural fluid, and then we see down here peritoneal fluid. But look at that pleural fluid, nice, clean, anechoic black. But you have this kind of gray hypoechoic fluid, that, again, that makes you worry about a perforation. We also, in areas in the right upper quadrant, we see these little wispy little guys do not belong in the free fluid. And maybe if you were to imply that there was inflammation going on for weeks, you might develop this kind of stuff. But this looks like bowel contents that have just poured out into the peritoneal space. This is their CT. Interesting, the appendix was the least remarkable of all, except that the appendix wall was really indistinct. That's not just because the are very thin cuts. This appendix, it's really hard to see. Appendix is kind of hard to see. Added bowel in the right lower quadrant. Fluid that's complex and echogenic was a patient with perforated. Tricky is the third spacing all over the place. The anasarca, the mesenteric edema, ascites, the pleural effusions. They can find the problem when the whole body is in shock. Appendicitis, always think about that. New pain, colicky pain. This diagnosis, we find classic for Intussusception. How do you Intussusception? Abduction is a great way. Is prone by, we see on the left, because the left is actually image left and patient's right is image right. You don't need a static standing pressure of 120 because that will increase your risk of perforation. If you see small bowel intussusception, we assume that it's not significant. Assuming there are no other complicating factors, which I'll show an example of in a second. You say, well, we see it, there's nothing you can do about it, you can't replace it with an enema. Assume it's just, and as long as it's not causing obstruction, just ignore it. A 2-year-old with abdominal pain, and what looks like maybe an early obstruction, bowel dilated, not that much, but it's out of proportion to the rest of the abdomen, and that's more important, that dilated bowel that's not commensurate with bowel elsewhere. And then we see in the central abdomen, kind of right around here, we see Intussusception, small bowel Intussusception. So, what is that? Well, if you take a closer look with a higher probe, Good thing where the small bowel has this little infolding right here. And then if you do that, it then kind of pushes in as though there's contents herniating from outside to in. Small bowel didn't have any defect on the wall, so you shouldn't have mesenteric type contents coming in. And your small bowel intussusception, dilated fluid filled upstream, and then it's obstructed here. What was this? An inverted Meckel causing small bowel intussusception. So I said small bowel intussusception can be mostly ignored unless it's causing obstruction. And if you see this sign where the bowel is actually getting intussusception from this infolded tissue here. So start worrying about tumors and other mass effects in kids. So let's see examples of that. This is a kid with a ventricular peritoneal shunt with throwing up. The first wonder about in anyone who's shunted is going on with their hydrocephalus. So this head CT is normal. So we're going to now make sure the shunt is working. We'll get an abdominal x-ray to make sure that there's no obstruction in the abdomen. And we immediately see the diaphragms are elevated, the abdomen is distended, the bowel is kind of, it's pushed up to the side. Now the transverse colon, it goes from right to left. So it's going to be just kind of mashed anteriorly. So we're going to get an ultrasound, and we're going to see that all of the abdomen is filled with anechoic fluid. And within that anechoic fluid space, only in that space is the catheter. There's no bowel in all this fluid. All the bowel is mashed up and pushed to the sides. So this so-called CSF Pseudocyst or a CSF-oma, basic peritoneum has failed to resorb the fluid, and you are formed in a pocket that's larger and larger as your head drains. Because it's a one-way valve, it allows fluid out of your brain, but at a certain point you kind of back up, and this can lead to hydrocephalus. So this is vomiting. To be aware of in any shunted patients, there's a lot of reasons they could be throwing up. You get hydrocephalus, you're going to get a CT or MR for that. You get shunt fracture, you get a shunt X-ray series for that. You know, pseudocyst, you get an abdominal X-ray and an ultrasound for that. So it's kind of cool because there's different causes in these patients. You know, it may just be that they, ate something bad and have an upset stomach, but you just check. So if you're a parent of a shunted patient, you're always stressed out. Anytime they throw up, you kind of do these steps. Diets, that can still cause throw up, and you need a lumbar puncture for that. Yes, again, that'll be by exclusion after you've done all of the above. So here from patient, 7-year-old, he's also shunted. Curious, it turned out to be unrelated. He is, and we saw a weird gas pattern. It seems like there's a body of colonic gas. There's more small bowel kind of pulled into the right lower quadrant. It could be maybe a meniscus sign here, but that's a fake out. So we're wondering, could this be intussusception? Kind of old for intussusception, but we find intussusception. If you find intussusception in someone who's older than 3 years old, you have to worry that there's some underlying abnormality. PET scan, and we see hypermetabolism in the bowel, but we see additional foci of uptake. Will have to be lymphoma. So anytime you have intussusception older than 3 years old, you have to worry about a tumor. Lymphoma, particularly Burkitt's lymphoma, likes to go to the bowel. Remember, B for Burkitt's goes to B bowel. Also with emesis, ultrasound, and CT, shows huge abdominal mass. It has some calcifications, seems to encase the vessels. It seems to be arising from the kidneys. It's arising above the kidneys and pushing the kidneys down. What's the classic stoma? Emesis. Like the pancreas is kind of enlarged here. What's going there is that tumor, kids don't really get pancreatic tumors. Yes, you can get some tumors in teenagers, but kids just really rarely get pancreatic tumors. Think about when you see enlargement is you worry about inflammation. This inflammation is even causing ductal dilation. Acute pancreatitis. The laboratories are going to be way more sensitive and specific for this diagnosis. Really will be used in pancreatitis to look for complications, ductal obstruction, cyst, gallstones, seal due for necrosis. The pancreas looks big. It look distinct. You look for pararenal edema, with edema that's extending in the retroperitoneum within a pararenal space. But on a teenager, our final category before we finish up. So I told you are kind of things that you're going to worry about in a teenager. Gas, some air fluid levels. The composition of the intestinal contents is too liquidy in a hypersecretory phase. So air fluid is non-specific. Could be hypersecreting because you have gastroenteritis. Could be hypersecreting because you have obstruction. And it helps explain why we didn't see that much gassiness on the X-ray, because all that was totally filled. But it's this speckly looking stuff. This stuff is usually what stool looks like. We'll call this, when we see it in the small bowel, we won't call it stool in the small bowel, we'll call it succus. So it's dilated with succus. Where we will do an enema with gastrografin. So in this case, well, the diagnosis in this case is this patient has cystic fibrosis with intestinal obstruction syndrome, also known as DIOS. And the reason that we are doing the gastrografin enema is because we are deliberately trying to suck water into the colon by using a hypertonic solution. By using a solution, we suck in the water to help us soften some of this stuff up so that they can pass this tenacious intestinal content, hopefully a surgery, which is otherwise going to be required if you can't clear this obstruction. So intestines are at fault. It's not like there's a narrow point. It's just that the contents are so thick due to the cystic fibrosis that they get trapped. So cystic fibrosis patients, we did not show an example of meconium ileus, which is actually the same problem where fibrosis in babies leads to intestinal obstruction. This rears its head again when you become a teenager, where for what reason, I don't know why in child life it's not as bad, but it seems more in babies and teenagers. The cystic just kind of rears its head. This is chronic pain and throwing up. We have showing thickening of the distal diffusion, and we painted everything that restricts diffusion as red. The bowel has reduced diffusion. We've overlaid it with this image, which is kind of cool. Diffusion out overlay. And give IV contrast. So we have all the signs that tell us that there is inflammation of the terminal. What we do could be infection, could be inflammatory bowel disease. This is chronic. We're going to think about inflammatory bowel disease. In particular, we're going to think about Crohn's, because in this case, there's no the involvement of the colon. So this is disease. For this is going to be MRI. CT is also great. It does involve radiation. So people will say you start with CT and then follow with MR, or start with MR and follow with MR. Trouble, of course, is you have to hold still. So the patient who has developed any delay, we felt that the risks of CT dose were not as bad as the risks of having to do sedation that would have been required to do an MR. So we opted for a CT for a patient with inflammatory bowel disease. You can ultrasound enterography if you have patients prep themselves the same you would for a CT or an MR or a colonoscopy. Spend the time looking at the bowel, you can get a great study. This is terminal ileitis. We see that the ileum is thickened and inflamed. Exactly what we got at a CT MR. Be a little bit lucky, and in patients who are larger, it may be more difficult to penetrate the subcutaneous fat. For patient, ultrasound also showing inflammation. What's curious about this is you kind of wonder, is there an Intussusception going on? That we're told when the patient was transferred to us with image. What we have to be aware of is colitis. You compress it, and you that there's Intussusception. Now, what looked like there was bowel within bowel was just redundant folds of inflamed mucosa. Colitis, you can definitely see it by ultrasound. You want to compress to make sure that you're not missing Intussusception, and vice versa, that you're not overcalling Intussusception. leukemia, neurotransplant, throwing up, dilated duodenum. In an image, we see that there's a narrow aorta to SMA angle. It should be greater than 20, and it's going to be somewhere between 6 and 15, which is the range in which you expect to see SMA syndrome. This is our diagnosis. It can be associated with loss for other reasons. That loss led to mesenteric fat being diminished so it doesn't buffer the SMA and help lift it off of the duodenum. Other effects, you can have recent scoliosis repair. Now your ankle is a little bit tweaked because you just straightened your spine. Diagnosis to make is one that surgically is no joke because your options are to do a gastroduodenostomy or to bypass a jejunal-duodenostomy. There are treatments for this. Usually the most conservative is going to be to put a feeding tube down beyond the SMA into the jejunum, get the patient kind of fattened up, and then hopefully get better. But the data isn't great either. The patient can get better in maybe months to even a year. So this is a diagnosis, both to make and to treat. So, you know, treat it with respect, I guess is my only take home for this one. So different age categories and how we kind of focused on different etiologies, congenital issues for infants, kind of mass effects in children, and then kind of more inflammatory stuff in teenagers. Again, not encompassing, but generally those are some of the prints that you want to think about. And then, wise, everyone benefits from an abdominal X-ray, more heavy kind of in infants, ultra heavy in children, and then start doing more of the advanced CT or MR in the teenagers. The take-home messages were, for one, abdominal X-ray is great. It tells you, is there an obstruction? Does it look like it's a mechanical or maybe a functional obstruction? In the setting of bilious emesis in the newborn, is it an upper obstruction or a lower obstruction? All those things are really helpful to triage and then what the next best step is. Gastrograph in a neonate, technologists may offer it to you, but that's it. When a trainee, the text, what contrast agent do I want? And I say, I don't know, what do you suggest? And then, you know, you'll probably be okay doing that for a little while, but there will be times that, you know, the technologist doesn't know and you make a bad decision. So as the doctor, you really need to know what agent, if you're doing something to someone, be it IV, and it doesn't matter. You really ought to know the properties of whatever it is that you're giving the patient. So hit home some of these points. Number one, the preferred. Wait, hold on a second. Hold on. I remember now. I was told not to review the answers to these questions. So I'll stop here. I'm going to turn up my volume. Yeah, so we may have to titrate it just right. I will do general questions at this point from quite hear the question. I'm actually going to switch over to the Cisco WebEx display. Is it possible to chat the question to me? Tweaking some of the audio settings.
Yes, but can you hear me?
That sounds better now. Yes, I hear you. Yeah, sounds good.
She's asking on ultrasound. On ultrasound, can you differentiate ileocolite from ileum on ultrasound?
How to treat the colon from the ileum?
Yes.
That's
Intussusception, your colic intussusception.
Got it. Okay. So when you have an ileocolic intussusception, you're going to see that the small bowel is dragged into the right lower quadrant, and you're going to see that the intussusception usually will catch it in the right upper quadrant. That's because that's where the intestines have been sucked into the colon. And so, knowing that the patient doesn't have malrotation should hold true. Right? Not had a had malrotation that moved your intussusception elsewhere. Small, you'll usually be able to distinguish because it will not have stool contents within it. So it'll be non-speckly, usually simple fluid or gas contents within the small bowel, both above and below the small bowel intussusception. In small bowel, you can usually see little funny irregularities, marbleization of the mucosa that will help you distinguish. And if you bear with me, I have a slide that shows that difference. Let's quickly switch slides to another one for a second. Now, you're just not, and to be perfectly honest, for the storytelling, I gave you the short version on that inverted Meckel's case. The long was, we were sure that it wasn't an ileocolic intussusception, so we took fluoro just to be on the safe side. And we suspected that we would see nothing, but that would help us reassure ourselves that, okay, we're not missing an ileocolic intussusception. I'm going to decide this talk, and I have some slides about small bowel versus colon that I think will also be helpful to what I just said. So if you look at the ileocecal bowel, this is the terminal ileum, and you can see how it has kind of a little bit of a bucking submucosal surface. Colon will have this more, it's usually air or stool filled. So see this picture, there's ileocolic intussusception because you found the ileocecal valve and it looks normal. The valve itself kind of looks like a pylorus. It looks like a cervix for that matter. Here is the ileocecal and the colon. So if you get this picture, you're absolutely sure you do not have ileocolic intussusception. So you wanted to have the perfect loud intussusception picture, this one. That would be what the sonographer would show you. If you did still see an intussusception in this patient, you would know that it's probably small bowel with a small bowel. That was a long. Was that satisfactory?
Okay. Any other questions? Another one?
Second, child with the chronic constipation and barium done with the Crohn disease, and depending the dilated colon, there are no classic features of the Crohn. The entity known as the functional megacolon. Did you comment about that functional megacolon?
I heard what you were asking. It sounded like you were asking about functional immaturity of the left colon. Is that correct?
There's that, but there's also the functional megacolon, where children present with chronic constipation, but the enema findings are basically normal. They do not demonstrate the features of Crohn, but clinically the children have chronic constipation.
Right. Okay. Those are super challenging, and as my on it, I think our job is to identify a transition point that would imply Hirschsprung's. If a transition point, that Hirschsprung still may be possible, but it'd be a very, very low, right, just above the anus essentially. And will often have their hands forced to do a rectal biopsy, even if radiographically it just looks like non-specific dilated colon. The kind of image one might consider is some people have suggested looking at peristalsis of the colon, either by ultrasound or by MR. One researcher at our hospital who likes doing manometry said, well, is colon functional? And does it respond to stimulants like bisacodyl is functional, then maybe they will benefit from aggressive constipation management and stimulant therapy. If not, they just need to then have an ileostomy, that colon is never going to do its job. Sense is that it's challenging to that an idiopathic entity with poor treatment options and a diagnosis of exclusion once we've made sure that there's no mechanical, thick, so to speak, cause. I take on those. Guys feel differently about it. It's first very challenging.
Any other questions? Thank you. All for the questions now.
Sounds great. You guys have a wonderful evening, and I will go to work. And I think I might be scheduled for you in the future. So until that time, farewell.
Have a
Thank you very much, and we'll see you next time.
Thank you very much.